Ken Landau. Thanks for watching. Let's talk about glipizide or glucotrol. This is a second-generation sulfonylurea. It's an oral medication to treat type 2 diabetes, in addition to diet and exercise. Diet and exercise are extraordinarily important. Even if you're taking some kind of a medicine, you still want to be on an appropriate diet. You want to try to get down to normal weight, and you want to exercise. That reduces the likelihood of cardiovascular complications and all sorts of other problems associated with diabetes. You take the medicine, it controls your sugar, at least partially. Well, it's not for type 1 diabetes. The drug's been around for a long time. It was patented in 1969. It was approved by the FDA in 1984. It's still in the top 50 prescription agents used in the country, with more than 17 million prescriptions written every year for glucotrol. Comes as available as an immediate release form, 5 and 10 milligrams, extended release form, 2.5, 5 and 10 milligrams, and now it comes in one pill combined with metformin, 2.5 or 5 milligrams of the glucotrol. Well, until 1995, it was the only oral class of medicine, the sulfonylureas, that we had to treat diabetes. And the glucotrol is now a preferred agent in the sulfonylureas because it has less of a tendency than most to cause hypoglycemia or cardiovascular events. You shouldn't take the medicine if you have type 1 diabetes. It just flat out doesn't work. If you have a tendency toward diabetic ketoacidosis, diabetic coma, hyperosmolar coma, drug isn't for you. If you're hypersensitive to sulfa drugs or the sulfonylureas, obviously don't take the medicine. If your kidneys don't work very well, the creatinine more than 1.8, again, probably not for you. It shouldn't be combined specifically with another class of oral anti-diabetic medicines, Starlix, Prandin. And if you happen to have something known as a G6PD deficiency, then if you were to take the glucotrol, it might cause a hemolytic anemia. Now, some people are well controlled on just diet and exercise. And for those people, when they get under a little extra stress for some reason, then the sugar might go up, and a short course of the glucotrol might be appropriate. On the other hand, there are some people who are well controlled with the glucotrol, and then with that extra stress, they might need some insulin because the sugar goes up a little bit too much. The extra stress might come from fever or infection or surgery or trauma. The medicine, if you take the immediate release form, should be taken about 30 minutes before breakfast. If you take the extended release form, you take it with breakfast because it's better absorbed from the intestine if you happen to have some food there. Start off with 5 milligrams, except if you're elderly or debilitated, you have liver disease, then 2.5 milligrams. With the immediate release form, you can increase the dose every 3 to 7 days by 2.5 or 5 milligrams, depending on how high the sugar is. If you're taking the extended release form, then you should not increase the dose more than once a week. You shouldn't take more than 15 milligrams at a time, but you might need a higher dose. It's not unusual for a person to be taking 15 milligrams in the morning, 15 milligrams in the afternoon. You shouldn't approach the maximum total dose. Maximum total dose would be 40 milligrams, but you don't go higher than 30 milligrams. And unfortunately, over a period of time, many people lose control of their blood sugar. That's a condition we know as tachyphylaxis, where it initially seems to work, but over time seems to lose effectiveness. One of the reasons, there are many, but one of the reasons is that you have downregulation of the receptors on the cell, so the sulfonylurea isn't taken up by the cell. You have to be especially cautious if you're elderly or debilitated, or if you're malnourished, or if you have impaired liver or kidney function and you're taking these kind of medicines. And if you're taking the immediate release form and you say, I'm kind of tired of taking 2 different doses during the course of the day and you want to switch to 1 dose, well, you could switch to the extended release. You could do on a dose per dose, but usually you could start off with 10 milligrams, or if you're new to the anti-diabetic medicines, you could start off with 5 milligrams. You don't chew the medicine, don't crush it, don't split it. You could add it to insulin. And as a matter of fact, if you're taking a relatively low dose of insulin and you want to switch from the injections to the pill, you could do that too. If you're taking less than 20 units of insulin, you could just stop it and start the glucotrol. If you're taking more than 20 units of insulin, then what you do is you cut the insulin dose by half as you start the glucotrol, and then you check your blood sugar, and then you can decrease the insulin as appropriate. Now, if you're starting off with the fixed combination of the glucotrol and the metformin, start off at a dose of 2.5 milligrams of the glucotrol and 250 milligrams of the metformin. That'll take care if you have a sugar in the high 200s. If you have a higher level, then you might need more of a dose. You don't go to more than a total dose of 10 milligrams of glucotrol and 2,000 milligrams of the metformin during the course of any given day. You can add the medicine, you can add the glucotrol to other anti-diabetic medicines, except for the Starlix, the Prandin that I mentioned a moment ago. When you start taking the medicine, you might have what we call primary failure. It might just not work. So there are a fair number of people who the drug just doesn't seem to work. You could switch to a different member of the sulfonylurea family. Maybe it would work. And some people, when they're taking the medicine and having relatively good control, over a period of time, you might lose the control. One of the reasons, as I mentioned, was because of the downregulation of the receptors, and the other is you might be gaining weight. There are a variety of other factors that are involved. The medicine seems to be well absorbed. About 80 to 100% of the medicine that you take is going to be absorbed. The immediate release form is going to have a delayed reaction by about 40 minutes if you take it with food. The other medicine, the extended release, you do take with food for better absorption. Protein binding is going to be in excess of 90%. It's going to localize in the extracellular fluid. It's not going to get into the brain or the spinal cord. The onset of action of the medicine is going to be within 15 to 30 minutes. That's why you take the immediate release form about 30 minutes before you eat. It's going to have a peak activity, peak concentration in the bloodstream after about 1 to 3 hours. The half-life of the medicine is going to be about 2 to 4 hours. But interestingly, even though it can have a negligible concentration in the bloodstream, it might still have some glucose-lowering, sugar-lowering effect for up to 24 hours. It's almost completely metabolized in the liver. 60 to 90% is going to be excreted in the urine. About 5 to 20% is going to be excreted in the feces. Compared to other members of the sulfonylurea family, glipizide or glucotrol seems to have higher potency. It has faster absorption, faster onset of action. It has a shorter half-life and a shorter duration of action, and that's good because that means it's less likely to cause hypoglycemia. Now, in a rat, it seems to have some fetotoxic effect, and the fetotoxic effect is due to the tendency sometime to have the low blood sugar, the hypoglycemia, but it doesn't seem to cause birth defects. But newborns born to women who were taking the glucotrol during pregnancy could have severe hypoglycemia for up to about a week. So that means that if a woman is taking the glucotrol or the glipizide, well, she should stop at least a month or so before delivery and switch to insulin. Insulin is a much better therapy for pregnant women. Well, if a woman wants to breastfeed, we know that some of the sulfonylureas do get into the breast milk, so it's probably not the greatest idea, and the safety and effectiveness for the pediatric population is not established. How does the medicine work? Well, it stimulates the insulin release from the beta cells. So you need the beta cells in order to have the medicine work. That means in type 1 diabetics who don't have the beta cells, they all died, then this medicine doesn't have a chance of working. Well, it's also very important to consider that if you're taking the medicine and you lose effectiveness from the medicine, you might want to switch to another sulfonylurea. It might work. It seems that it doesn't increase the insulin level during the entire course of a day. It just increases the amount of insulin, what we call the stimulated insulin response to food. So after a meal, then you make more insulin, and that pushes the sugar down, and then the insulin level gets back down to whatever its baseline level happened to be. It might also have an effect outside the pancreas. Well, it seems that it increases the amount of sugar production inside the liver, but it decreases the amount of sugar that's being put out by the liver, and it also increases the sensitivity of the peripheral tissues to insulin. That means it increases the number of receptors for insulin in the muscle, and the fat, and the liver. And then it does a variety of other things inside the body, all of which seem to enhance its activity. So does it change the lipoproteins? No. Does it tend to cause a fluid buildup? No. Well, it's in the second generation family. So the first generation family of the sulfonylureas were the chlorpropamide and the tolazamide and tolbutamide. They're not used much anymore. But we have the second generations, glucotrol, probably the first choice. And then we have a drug that sort of sits in the junction between the second and third generation. It's called Amaryl. There's a black box warning that it could increase cardiovascular mortality. That's from a study done in 1970s at the University Group Diabetes Program in England. And what they did is they looked at people who were assigned to the first generation drugs, and they considered how they did compared to people on diet, people on insulin. And what they found is that the people who were taking the first generation sulfonylureas after a period of 5 to 8 years seemed to have a 2.5-fold increase in the cardiovascular death rate. Well, that obviously isn't very good. But interestingly, the all-cause mortality wasn't different in the group receiving the medicine and not receiving the medicine. We'll talk about that in a moment. Other side effects of the medicine are hypoglycemia. Hypoglycemia, relatively low incidence. In the first year, it's less than 2%. So that's relatively good for an anti-diabetic medicine compared to, say, glyburide, another medicine in the family, that has a 2 to 3-fold increase in the incidence of hypoglycemia compared to the glucotrol. Symptoms of hypoglycemia, increased heart rate, feeling drowsy or agitated or confused. Some people have blood pressure that goes down, or seizures or coma. Hypoglycemia, you have the greatest risk if you have kidney or liver impairment, if you're debilitated or malnourished, or if you're taking more than one anti-diabetic medicine, if you're drinking a little bit too heavily. All of a sudden, if you decide to start an intense exercise regimen, or if you're elderly and if you're calorie deficient, you're not eating enough. The most common side effects of the medicine: nausea and diarrhea and constipation, stomach ache, loss of appetite. Some people vomit or have heartburn or nervousness or tremor, or increase the flatulence, gas. Some people can develop allergic reactions to the sulfonylureas. That's not all that uncommon. Some people develop photosensitivity, especially in the summer, in those areas that are exposed to the sun. And some people develop what we call a disulfiram type reaction. It's the same kind of reaction that people who are alcoholic, who take Antabuse, would get, where they have pounding headaches and they have blood pressure that goes high and the face turns red. Some people taking the medicine develop a low level of either their white blood cells or their platelets, or they could develop an aplastic anemia or a hemolytic anemia. Well, drug interactions are not all that uncommon. So if you happen to be taking the glucotrol and then you add some aspirin or nonsteroidal anti-inflammatory drug, or you take a sulfa antibiotic, maybe because you have a urinary infection or if you have a yeast infection, you're taking miconazole, or you take probenecid or warfarin, MAO inhibitor, or a beta blocker, those could push the blood sugar even lower. And if you're taking any other kind of a medicine that pushes the glucotrol off of its protein binding sites, then there's more free medicine to push the sugar down. So that's a concern. On the other hand, we have the opposite situation, where if you're otherwise well controlled and now all of a sudden you start taking cortisone, or prednisone, or you're taking a thiazide, a water pill, antihypertensive medicine, taking a phenothiazine like Seroquel or Zyprexa or Risperdal, or you're starting a birth control pill, or taking estrogen or Dilantin or a calcium blocker, or you're taking an anti-tuberculosis medicine, then you could lose control. The blood sugar might go up. Now, if you overdose on the medicine, what's going to happen is your sugar is going to go down. And if it's a mild reaction and you don't take too much of it, you're not going to lose consciousness, you're not going to have neurologic findings, you just have symptoms of hypoglycemia. However, if you take a lot of the medicine, then you could have seizures or neurologic impairment, or you could have coma. Obviously, that's very important. Now, there have been no studies that show that you can reduce the likelihood of microvascular complications of diabetes by taking the medicine. You don't reduce the likelihood of kidney disease or nerve disease or eye disease. And that's, again, why diet and exercise are so important. If you go on a diet and exercise program, then you can reduce the likelihood of those kind of complications. And you have to remember, diabetes is principally a vascular disease. It's not a disease of blood sugar. It's a disease that has to do with your blood vessels going to the eyes and the kidney and the nerves and to the heart. Well, if you're diabetic, you have to pay a special attention to control of your blood pressure, your lipids, your body weight. You got to get out there and be physically active. You got to get off the cigarettes. Well, let's get back to that university group diabetes program from England in the 1970s. What it clearly showed was that tolbutamide, that was the medicine they were using, that's the first generation sulfonylurea, that did increase the incidence of heart attack and stroke. So it increased the risk by about 1.2 individuals per 1,000 patient years compared to, say, taking a different drug. But if we look at the all-cause mortality, it was not increased. Actually, on 10-year follow-up, it seems that the all-cause mortality decreased by about 13%, and the incidence of heart attacks decreased by about 15% versus the usual care. Now, in another study that looked at the sulfonylureas, and this is all sulfonylureas, first generation, second generation, it was found that there was a 20 to 70% increase in cardiovascular disease and hospitalizations and in mortality from taking the drugs. And they did a large Veterans Administration study. They looked at about 90,000 to 100,000 people taking the sulfonylureas, compared them to about 150,000 people taking the metformin. And they found that the people who were taking the sulfonylureas, yes, indeed, had about a 15% increase in the combination of heart attacks and stroke and death. Well, it's important to realize that different sulfonylureas have different side effect profiles, and it would appear that glucotrol probably is about as safe as you can get in the sulfonylurea family. Now, if you have cardiovascular disease, it might be a better choice to take a drug like Invokana or maybe a drug like Trulicity. Those drugs don't seem to increase the risk of heart attacks. But now we're learning that heart failure, which is different than a heart attack, heart failure is your heart is just not pumping enough blood on a chronic basis to take care of the metabolic needs of your tissues. Well, heart failure probably is increased in anything that increases the amount of insulin in the system. So if you take insulin, you're going to increase the incidence of heart failure. You take a medicine like Actos, going to increase the risk. If you take a drug like Trulicity or Ozempic or Victoza, probably going to increase the risk of heart failure, worsen the course of heart failure. Januvia, increase the risk of heart failure. Just all of a sudden, over the period of the past 5 to 10 years, starting to study more about heart failure rather than just the heart attacks. And the sulfonylureas increase the amount of insulin, so they too can increase the risk of heart failure. So that's obviously something to be considered. And that's also reason why you want to consider diet and exercise. Diet and exercise. Does it increase the incidence of cancer? No, most of the studies show it doesn't do anything with that. How about when you test the glycosylated hemoglobin or hemoglobin A1C? Well, people who are on oral medicines should probably test the A1C about every 3 months, every 6 months, realizing that over time, the medicine probably is going to become less effective than it initially was. And part of the reason is the burnout of the beta cells in the pancreas. So you just don't have as many cells as you did once upon a time. So the failure rate over a period of time is probably going to be about 20 to 30%, maybe even up to 40%. So monitoring, yes, indeed, you monitor your blood and your urine sugar over a period of time. Monitor every 3 to 6 months the glycosylated hemoglobin, hemoglobin A1C. A good measure of how you're doing on your diabetes is just get on the scale, see what your weight is. If your weight's going down, chances are you're going to do fairly well. Your weight's going up, chances are you're going to do not very well. Periodically, you need to check the kidney function, simple blood test, the BUN and the creatinine. Unfortunately, only about a quarter of the people are going to reach the goal of a glycosylated hemoglobin of less than 7%. And as a matter of fact, 50% of the people who initially get there are going to lose control. Now, when you pick the medicine for diabetes, there are a lot of reasons to pick certain kind of drugs. Typically, we start with metformin for type 2 diabetes, but then when we add a second medicine, we have to consider the safety and the efficacy of the medicine, the tolerability of the medicine, your preference. Do you want an injection? Do you want a pill? How well the sugar is going to be controlled. What other kind of diseases do you have? How many pills are you taking for diabetes and other conditions, other comorbid conditions that you happen to have? What are the side effects of the medicines? How much do the medicines cost? What's your body weight to begin with, and how likely are you to suffer from hypoglycemia? All of those need to be considered. Well, obviously the goal is to reduce the sugar, to reduce the glycosylated hemoglobin, to decrease the number of other diseases that a person has. And the Endocrinology Society say our goal should be a glycosylated hemoglobin of less than 6.5%. But they say we can individualize it depending on your goals and depending on your age and depending on comorbid conditions up to maybe 7 or 8%. On the other hand, the American Diabetes Association says, yeah, less than 7% is really good. You don't have to go to less than 6.5%. The tight control isn't really necessary for many people, especially people in their 50s and 60s. And for people who have comorbid disease, maybe we don't even care as long as you're less than about 8%. Well, you usually begin with one medicine, but if you're not controlled after a period of about 3 months, you add a second medicine, and another 3 months, you add a third medicine. However, if your sugar is extraordinarily high, or if your glycosylated hemoglobin is extremely high, say more than 11, then chances are you're going to begin with insulin. Most of the medicines will be able to reduce the glycosylated hemoglobin by about 1 to 1.5%. Now, according to the American Diabetes Association, there are lots of options available, and they don't really seem to have any preference to which one you add as the second medicine. You could add the sulfonylureas, you could add medicines like Actos or Januvia or Invokana, or you could add Victoza or Trulicity, or you could add you could add the insulin. The Endocrinology Society, well, they have a hierarchy, and they think that the sulfonylureas might be one of the last medicines that you add. Well, if a person has a very low level of glycosylated hemoglobin, less than 7%, then it's much more important that we pay attention to the blood pressure control and the lipid control, get off the smoking, exercise, consider whether you need to take an aspirin a day. The American Diabetes Association says, you know, cost is often an issue. These medicines cost an awful lot of money. So for most people, start off with the metformin and then consider as the second line treatment after you're on the metformin. If that's not enough, then add a medicine like Glucotrol or Actos. Now, if we're worried about hypoglycemia, then you want to stick in the family of the sulfonylureas to the Glucotrol or the glipizide. That seems to be the best. Well, how much do the medicines cost? The good news, the great news, is that you can take the Glucotrol or the glipizide, you can get 60 tablets at 10 milligrams for anywhere between $4 and $17. And if you bought the brand name, it would cost $200. But on the other hand, if you want Januvia, it's going to cost more than $450 with a coupon. If you take Trulicity, it's going to cost somewhere between $650 and $800. Invokana going to cost about $500. If you take Ozempic, it's going to cost you about $800. So diabetes is extraordinarily common, and it's becoming even more common because as a society we're getting fatter. And it seems that the incidence of type 2 diabetes is parallel to the likelihood of being overweight or obese. So for some people, a pill might be an appropriate second-line therapy after diet and exercise. But really, if you want to reduce the likelihood of the cardiovascular complications and some of the other problems with your eye or with your kidney or with your nerve, if you happen to be diabetic, you better reduce your weight. That's the primary goal. Still diet and exercise. And if you fail in diet and exercise, then it's metformin. And then you could consider a medicine. And according to the American Diabetes Association, most of the medicines for the average individual would be acceptable as a second choice. And that would include the glucotrol or the glipizide. And remember, it's still among the top 50 prescription agents in the United States. But if you reduce your weight, then maybe you're not going to need the medicine. Anyway, thanks for watching. If you enjoyed the show, please tell a friend, consider subscribing. As always, appreciate your interest. I'm Dr. Ken Landau.